And welcome to the 2015 Hospice Awareness Series. We're going to get started with our series with Waynetta Rodgers. She works in the hospice industry, and it is Hospice Awareness Month for November, so this will tie in really well with this series. And Waynetta, it's good to have you with us.
Thank you.
Familiar face, so.
Yeah.
So we're going to talk about hospice throughout this month with different people and working within the hospice industry. Basically, this will be a good information piece for people out there that themselves or their family could be utilizing the services of hospice. And as I understand, the services within hospice have really expanded over the years. So there's probably a lot of things concerning hospice that people don't know about.
That's right. That's what I run into the most as a community educator with hospice. And what that means is that Medicare actually requires that each hospice company, agency, have a certain amount of education that we put out there for them. And so it's important that I know that I'm updated on the newest things, everything, or any changes that happen with hospice. And what I run into the most in educating people is that most of the time they know nothing at all about hospice. They have no idea. They think their basics about hospice is that a person is getting ready to pass and then hospice is called in, or that they've utilized hospice before with a family member or with a friend, and so they think that they know everything about hospice already. And then when you inquire with them further, you find out that it's been a while since they used that hospice care, or perhaps that person only used hospice for a short amount of time, even a week or a few days. Sometimes it's just a few hours. And so they haven't really got to experience all the different things that hospice has to offer because of that short amount of time that that person, was admitted on. And so through education, and I go talk to clubs, different organizations, healthcare organizations, nursing home, assisted living, clinics, hospitals, any type of, like maybe churches will have specified little groups, maybe it's a 30s class, or it's a senior saints class, something like that, and I'll go in and I speak with them. So anybody that's at all, that's any type of a little group, then I'll go in and do an in-service and give them an opportunity to ask questions so that they can get those misperceptions that they have corrected. And when people have correct information, then they can turn around and share it with others, and that's how that education just continues to grow and expand. I've been with hospice for 7 years now. You know that. You've been with me for those 7 years nearly. And I was one of those people that whenever I was asked if I knew what hospice was about, my answer I'll never forget. I said, I think that it's when somebody's getting ready to die, and I think that maybe somebody goes in and holds their hand or says a prayer with them or something like that. That's all I said, because that's all the information I had about it. And then when it was shared, the different things that we do, and nowadays there's even more, we can take care of more types of illnesses for a longer period of time in a more efficient way than we ever have before, then it was just startling to me what hospice was really about. And that's my drive for getting up every day and going to work. It's like, who out there is still where I was 7 years ago, and they need or know someone who needs this help, but they have no idea that it's out there. Excuse me. So nowadays it's what people are looking for. They're looking for the resources, because we all know that in the healthcare system that there are a lot of cuts that are being made. Mm-hmm. And because of those cuts, it does make it more difficult on us, anybody, to be able to find a doctor and then be able to get, get the equipment, the medications, the therapies and different things that we're needing. It's just it's tougher than what it used to be to get those things. And so what we found is that hospice was designed to save the healthcare system money. And it is one of the few resources out there, if not the only one, that I've seen that actually gives more medical attention but saves money. And that happens through the different types of services, which are going to continue the series, and people will find out each week, what part of hospice and what they do that expands on people's normal health care, that regular doctor visit, that they're making. So I'm going to hit on some of the concerns that I get. It's very common for me to have people say, well, I thought hospice was just when somebody was getting ready to die. And they associate that with the term terminal illness. Terminal, if you look it up in Webster Dictionary, terminal means that it's an illness that there's not a cure for. That can become life-threatening. That's the next part of it, okay? So macular degeneration, there's not a cure for that, but it's normally not a life-threatening situation. It's very debilitating, but not life-threatening. So a list of the illnesses that we see most often, I'm going to read them off this sheet because I don't want to miss any, but we have Alzheimer's, then also dementia with Parkinson's, cancers of any kind where a person is at a point that they've exhausted all treatment, or they're at a point where they don't want to continue treatment with it. COPD, which involves a lot of different pulmonary diseases. There are 5 different ones that covers. Congestive heart failure, CHF, and I'm giving those acronyms because a lot of people may say, oh, I have COPD, but they don't really know what COPD is. So CHF, which is congestive heart failure, then also multiple sclerosis, ALS, kidney disease or renal failure. And nowadays, with that illness, we do see where more people are using dialysis. It is able to extend their life. It is able to give them quality of life. But at some point, those people recognize that this is no longer giving me good quality of life, and at some point dialysis, may not work for a person anymore. So at that point, when they drop off of dialysis, then they'll, go ahead and pick up with hospice care to keep them comfortable during that time. Then cirrhosis of the liver. There's a lot more of that out there than what we actually, people that we reach. That's one that's really kind of, I don't know what to call it. It's an illness that, we're not seeing much of it that we're taking care of in hospice, but there's a lot of it out there that we could be taking care of. So that's a concern for me. Then stroke. And stroke is whenever a person is no longer, you're really not seeing a rehab with it. That's when a person is pretty much bedbound. They're requiring help with their their daily living activities. You will have people who have a stroke. We all know of someone who's had a stroke. They're rehab. They're up now. They're able to walk. They're able to use their, left side more. They still have some, again, debilitation with it, but it's not life-threatening for them anymore. And but you have other people who are taking medications because they have continually have strokes, and so it could take their life at any moment. And so they're taking medication to help with that risk, but the risk is still there. Then HIV/AIDS, and we don't see as much of that either anymore because AIDS is more controlled, with medications now than what it was, which is a wonderful thing. Yeah. But you do still have some of that out there. And then there are other terminal illnesses, and these are the ones that have names like this long that I can't pronounce. And, you may have an infant or a child that has one of these rare types of diseases. Had someone that mentioned an illness that a child had. It's called moya moya. Who's ever heard of that, But it would be an illness, and we found out that it is covered through hospice. It, is a appropriate illness for us to be able to help with. And while I'm saying that, I'll go ahead and throw in that if you find a hospice company, the one that I work with does, now not all do, but that will do pediatric hospice, then that child can still be receiving hospice care and seeking aggressive treatment, which is wonderful, because we have all these extra services we'll find out about in the following series that family can have that's going to be very, beneficial and just be great support for them while they're still, working with what aggressive treatment is a treatment that you're taking that you're trying to seek a remission for, okay? So chemo and radiation, those are having a treatment that is more aggressive, trying to find a remission. It doesn't mean that you definitely can, but you're trying for that. And so as long as you're seeking aggressive treatment, then hospice wouldn't be appropriate, because Medicare, Medicaid, VA, private insurances, they're not going to financially, they're not going to allow you to being over here trying to find remission, but at the same time you're looking at end of life types of measures. Those don't coordinate with each other. Now, when I say end of life, that again, it doesn't mean that person is what we call actively dying. What we're saying is that their illness has gotten to the point that they are at risk for a life-threatening situation. So something like an Alzheimer's patient, what's common for them is a urinary tract infection, a UTI, because they don't have sufficient input and output. So when they have a UTI, that can be so severe that person would lose their life. And so they need to have the proper medications to, treat the UTI. What hospice is wanting to do is we're being aggressive in this way, I guess, is we're wanting to get in there and make a regular visit so that we recognize the symptoms, because we already know that this person has Alzheimer's. We already know that nurse knows what the symptoms are of that illness. Therefore, she knows exactly what to look for when she goes in to see that patient, to see if they have some of those symptoms, knowing that, hey, I need to get in there. If they have a fever, we may have a UTI going on. Let's go ahead and get this person set up on the right medications to try and ward that off. So that's where you will hear that the statistics show that a person lives longer being on hospice care than not being on hospice. And that's a perfect example of how, because we can help them over those bumps that could be mountains, for them, by being aware earlier on, And so if a person is having a regular doctor checkup, and normally a regular checkup is going to be once every 3 months, okay? So even if they're seeing them once a month, if that progresses and the doctor's seeing them once a month, then is that doctor able to recognize that somebody has a fever and there's a UTI, and get in there and get that taken care of? Usually what the option is before hospice is we wait until something is bad enough that it justifies going to the emergency room, and then many times you're already full-blown with that particular life-threatening thing, and then that's when you may not make it back from that. And so there's where we're more efficient, and definitely, you're getting a more immediate care by being in there. More efficient in the fact that we know your history. We're in there seeing you on a regular basis. We know what you were doing last Thursday, We knew what complications that you might have had over the weekend, that we addressed, that type of thing. So, it's a day by day knowing what's going on.
Would you say there's a reluctance from people that could take advantage of these services or seek out hospice, because there's kind of a conventional wisdom that the hospice is for kind of end-of-life scenarios? You think there's a reluctance to consider hospice in a lot of ways?
Yeah, definitely. And where that comes from, it's a cycle. I say a vicious cycle. But when they asked me 7 years ago, what do you know about hospice? Okay, my reaction was pretty similar to what anybody else out on the street would have, any of us, just in the general public. Because that's how hospice originated. And so when when you're not getting more information, when you're not getting more education about something, and you see it being used that way, then you assume that's how it is. So when it's time for you to utilize it, then you're gonna follow suit of what you've seen, because you have no education here. And so you utilize it that way. Well, then your friends and family and everybody see how you use it, so then that's how they utilize it. And so that's been a continual thing over the years. And so it's just been like word of mouth and getting out. You're not going to see a campaign for hospice. I think it's coming. I do, because the way our healthcare system is being run right now, I think that it's going to get to a point where hospice is going to be, people are going to really see that, wow, we need this to supplement, what healthcare that we're getting. But for now, you're not going to see a campaign on it. So it's just people like me that are going out here, day by day, seeing a few people and getting the information out and hoping
Sure.
they're sharing it with other people.
Yeah.
So yes, definitely there's that reluctance because that's their knowledge of it. They think that that's how it's used. Hospice was actually designed to use for at least 6 months, if not longer.
Yeah.
But people took that. I don't know, somebody started that. I don't know who, but it was like, okay, well, if you're going hospice, you only have 6 months to live.
Yeah.
That's where that came from.
It's
We
not
have-
it's not necessarily a long-term resource, but it is a resource in a short period of time to enhance your quality of life and get you past a kind of a bump in the road, as you
Right.
said.
Or when it comes to the point that it is time for your life to end. We all know we're born to be, we're created to be born, and then one of these days we're going to die. We all know that. So at some point, your body is just going to want to let go, and there is a natural process that, and these are things that visually nurses can see, doctors can see. And so when that point, that's what we call actively dying. You cannot reverse that, But what you're doing is you're trying to make that as comfortable as you possibly can, not only for the patient, but also for the family, helping them to understand that these are natural things that happen with the body. This, we give them information ahead of time and saying, these are things to look for, these are things that are going to happen, instead of you saying, I don't get it, Mom keeps talking about going home. She is home. Well, that's because for her and her spiritual, beliefs, there is another home. So that's what they're actually talking about, their home after they pass, not their physical home that they're in right now. So when we give them that information, then the family doesn't, they're trying to fix that because Mom, and you're saying, but Mom, you are home, and they want to make her understand. You don't have to do that, You can take solace in the fact, comfort in the fact that this is why she's doing that, because she's preparing in her mind to go somewhere else and she's looking for her other home, She's good with what you're doing. So that gives comfort to the family as well. But yes, and we do have people that come on hospice care, and we bump up their level of care to where they're actually maybe had been, their illness had been worse just simply because they hadn't got in a good, what's the word I want to use, where you're doing everything you're supposed to, like taking your medication like you're supposed to, when you're supposed to, or on your oxygen when you're supposed to, and all that, taking breathing treatments in a regimen, there you go. And so we help them to get on that right regimen, tweak the medications to where they're working well for them, and then they hit a plateau and they're doing great and they're not seeing a decline. We can release them off of hospice with just glorious. It's a wonderful thing to be able to do. But because there's not a cure for the illness, eventually they will see a decline, and so we're right there, go ahead and help them again.
Yeah. So, these illnesses that you listed, if anyone out there has their family or friends that are affected by these illnesses, should they at least contact any hospice provider and see what can be done for them? Would that be an ideal thing for them to do?
Yes, so ideal. What I've said this morning to someone, I say this a lot, but this is how I feel about it, is that just in my knowledge, things that I've, over the years and working with people and talking with patients and families, I believe that when a person is first diagnosed with any of these illnesses, that's when you should call hospice, because at some point you're going to be using it. Or it's going to be a resource for you that you need to be using, that you'll want to use. So get your information now. Don't wait until it's the point where the doctor says, okay, well, I can't do anything for you. We need to contact you with hospice. Gosh, you're already, it's already a shock that they're saying can't do anymore. And then you have to go out and find something that you know nothing about and get information, because they'll give you, if you're leaving the hospital or whatever, they're going to give you a list of hospice companies, and then you're sitting there looking at them, and you're in this stressful situation, possibly in an immediate situation where you need to get that care. Who do you choose? How do you know which one is providing what is best for you? Because that's what you need to do, is ask the questions, because everybody's situation is different. And so if you have one hospice that, they will be able to take care of that particular need that you have, then, when you're talking to them and getting information over the phone, asking questions or going to visit with them, that's what I do. I answer questions for people. I give them this sheet and I say, I can answer questions over the phone. Just give me a call.
Yeah.
And then they'll know ahead of time so that when that time comes and it's said, or the decision is, well, now, because you have the understanding of what we can do and who we can help and when we can help, you can say, well, now I think we need to go ahead and call hospice, and you know what they're going to be able to come in and provide for you. And most, it's sad, but statistics show that most people, even though more are using hospice all the time, that's a great thing, but the average time that they're utilizing is 7 days or less. And that's crazy when you could have had it for at least 6 months, if not longer, and you're getting 7 days of care. With all the different things that we, are able to provide that save people money ahead of time, and all those little, like I said, those little bumps in the road, all those things that you could have had a lot of different types of support with. Some of the things that I do want to hit on real quick is that there's in-home care that a lot of people that are on Medicaid, they have in-home care. That's where they go in and they do they do a lot. They run errands, they do respite care sitting with people, and they're doing, what's more common people understand is they're doing housekeeping for them and doing, cooking for them, that type of thing. Hospice is not in-home care. Mm-hmm. And we don't interfere with that in-home care. So people don't have to be afraid that they're going to lose their in-home, because you're not. Matter of fact, we even help them, and that's another part of this series that you'll get where they'll talk about how we help people to attain some of those services. So don't worry about us, interfering with in-home care at all. Also, that we do still utilize the hospital with our patients. You're not going to have somebody, if we have somebody that we have on services for pulmonary disease, but they're at risk for a stroke, we're not going to, first of all, take their, blood pressure medication away, because they have this illness that's considered terminal. We don't want them to, have other health problems. So I tell people we're in there to keep them as healthy as we possibly can, even though they're dealing with an incurable illness. So all those other things that you have happen, if you get the shingles, well, we're going to try and help you with shingles, even though that's not something that we're actually directly in there for. Along with your attending physician, you still get to see your doctor. Then we work together to help you, with your general health care, as well as specialize in that one illness that you're looking at. But if we have a patient who, and this is if they would be able to have a surgery, okay? Some people, they're not able to, okay? But we know that. But I always use the example, if they have appendicitis, we're not going to let them lie there, and have a burst appendix and die. We're going to get them. We want them to go to the hospital and get that taken care of. But people tend to. That's an old thought, is that you can't see your doctor anymore and you can't go to the hospital anymore. So I do want people to understand that those.
So basically, it's trying to take down the stigma of just last days care,
so.
but more of a resource of, if you're dealing with these illnesses, it's a resource available to enhance your quality of life at any point after you discover or diagnose with that illness.
That's exactly right. And so that's what we're there for. That's the community educator's position, is to talk with a group, to talk with an individual family, to talk with a patient themselves, whatever's appropriate, to answer all their questions and give them information. This sheet that I've been getting out is called, I just called it, the hospice I work with presents 10 hospice facts. And these are just 10 things that that are thrown at me on a regular basis every day that people don't understand. And when I share it with them, they're like, I had no idea. Yeah. And so then they're open to it. So your first step is always to get the information. So you're going to want to call a hospice company, and then ask to speak with someone who gives their education on hospice care, and find out now, because none of us ever know. Yeah. I mean, I could need it right now. People say, hey, how's your family doing? We're all doing great. Right now, today we are. Mm-hmm. But this time next week, maybe we're not. And so that's when you want to find out what your resources are and get all of your information, get your ducks in a row so that, you know, if it comes up where there's a resource you can use, then it's there for you.
Sure. And that's what we're trying to do with this series, to educate about hospice care, as she's mentioned, Waynetta's mentioned throughout the program, that it's come a long way over the years. That they've really extended their services and what they're able to provide for people with various illnesses. And it seems like they've got a lot to offer. And with it, whether it's any company that you seek out concerning hospice care, there's a lot to learn. I probably got a lot to learn myself, even though Waynetta's educated me quite a bit over the years. So, you know, there's quite a bit that they can offer. If you've got family or friends out there that you can give a word to, hey, you know, the person that you know, your family member is suffering from this, seek out hospice. At least find out what they can provide to alleviate some of the burden or just anything that's going on with those typical illnesses. So that's quite a resource to take advantage of for everyone out there. So yeah, it's good to know. We're going to have some other people to come in and talk more in depth about those particular services that you touched on. So we'll have that in our series as well. But November is Hospice Awareness Month, so it's a good time to talk about hospice in general and what it's able to provide, and just make a better quality of life for everyone out there.
I appreciate you letting me come in so much, because you know this is near and dear to my heart. And so it's wonderful that I get the opportunity, because this is just another way that I can get that information out there, besides always, you know, having to hit the street to be able to come in here. I appreciate YHC so much, because very informative in a lot of different ways. You know, I've been with YHC, which I know it's been a while, but you know, I've been with them for a long time too, and I always encourage people on being able to get good information because of you doing, you know, programs like this. So I appreciate it.
Good. So we'll be looking forward to some more people coming in with this series and explain more about hospice throughout this series. And Waynetta, anything else you'd like to share?
I think that's pretty much it. Just know that referring, just letting people, and I can go ahead and give my telephone number, I guess,
Sure.
right? This is my telephone number. It's 636-485-7202. And also I'm in the phone book. Bernie, it's Jeff Rodgers, and so that's me. And you can call me at home, or you can call my cell phone, either one. Leave a message. If I don't answer, I'll get back with you. And that's just to give you information over the phone, answer any questions that you have, so you don't have to feel reluctant about, you know, somebody, you know, pounding you or anything like that. Just answering any questions that you have. So please give me a call if you have any questions.
Okay. And Waynetta, appreciate you coming by and getting started with our series here to keep the people out there informed about the hospice industry, and we'll look forward to having more people in.
Thank you.
All right.